Hi, the following content is for educational purposes only and does not constitute medical advice. If you are a healthcare provider, please consult with your affiliated institution or local ethics committee for ethical guidance related to clinical practice.
Welcome to Module 7. Take it away, David.
Thanks, Russ. Welcome to Module 7. For today's topic, we're going to be talking about CRISPR technology. But before we get to CRISPR technology, we want to give you some more basics, and especially really some of the basics for understanding research ethics. So we're going to first start with the history of research ethics. We're going to talk a little bit about the Belmont Report and the regulations for how we look at research ethics. And that'll be all we're going to really be covering in this video.
Sounds good.
The history of research ethics. So back in 1947, so before 1947, there was no codified like guides or codes or oversight or regulations for human subjects research. And in fact, there's a very famous research study that was done where in the 1830s, a frontiers person, a trapper, a hunter, was shot in the stomach. He'd also been a soldier. He was shot in the stomach and he survived. And his surgeon found that he was able to had an open fistula, and he was able to put things into his fistula and study how the
is a big infection that's communicating with the outside.
Yeah, so he basically had an opening, and the guy built a plug between his stomach and the outside, which allowed him to put a hook on the plug to stick different things in his stomach to see how the stomach acid worked and study this. The patient's research subject's name was Alexis St. Martin, and the surgeon was named William Beaumont. And he did all these classic studies that were really, really seen as really important for the history of research ethics. But then there's a point where the research subject ran away, and there's a line in Beaumont's journals where he says, "I went to get the police to try and go after him, but he fled to Canada." So clearly, research ethics was very different back in those days. In 1947,
which is a very significant and obvious date if anybody's paying attention to history.
Yes, so that was the Nuremberg trials, the aftermath of Nazi atrocities in which horrifically bad things were being done by researchers and physicians in the concentration camps. Things like intentionally dyeing people's eyes and blinding them to see if they could turn people's eyes blue. They wanted to know at what point humans froze to death so they would freeze people together. And the aftermath of that, the first really codification of research ethics that emphasized voluntary informed consent was promulgated, and that was in 1947. In spite of the Nuremberg trials, it's nonetheless the case that most research that was being done on humans in this country and in Europe actually did not involve the informed consent of any of the participants. And in fact, in 1966, Henry Beecher published a very famous New England Journal of Medicine article in which he demonstrated by looking at a bunch of the top trials published in the top journals and found that most of them had absolutely no informed consent. As a result of recognition that Helsinki was not fully being formed, the first new declaration was created in 1964, and it's called the Declaration of Helsinki, and it's been updated several times since. And that really created for the first time the idea that there needed to be some level of independent oversight for the protection of subjects. Here in the US, and Helsinki, I should say, is actually one of the bases of research regulations in most of the rest of the world. So it's been updated many times, and in most of the rest of the world, Helsinki serves as the basics for research ethics. In the US, we don't use... Yeah, non-US.
Okay.
But here in the US, we wound up following a similar parallel path, but a little different. Partly what happened in the US was motivated by a series of scandals, the most famous of which was a scandal that broke out in the early 1970s over a research, I can't even call it a trial, research study that took place between 1932 and 1972, and that was the famous Tuskegee syphilis trial. And the revelations of what was terrible about the Tuskegee syphilis trial, which we'll talk about more in a little bit, gave rise to a recognition that there were problems. The result was that a presidential commission was created to address research ethics that produced a very famous report called the Belmont Report. And one important difference between the US and Helsinki is that Helsinki had a set of rules and a code of ethics, but it didn't have any theoretical underpinnings. And the Belmont Report really became the underpinnings of all of the research ethics, both in the US and as well as for Helsinki. In 1981, the first version of the current regulations in the US, sometimes called the Common Rule, were codified as a result of the recommendations of the Belmont Report.
Why are they called the Common Rule?
Because these are not statutory regulations. So instead, this is it's more formally known as 45 CFR 46. And that's the regulations that all of the agencies in the federal government have all agreed to for regulating any activity that they're involved in any way. And that includes any institutions that take federal funding, as well as anything that requires FDA approval. So usually this is what's followed. There is a loophole because it means if you don't take federal funding and you're not seeking FDA approval, you don't have to follow the Common Rule. However, if you want to get published, almost all journals require that you meet the standards of the Common Rule in order to get your article published. So the company 23andMe, for example, because they're not party to the Common Rule, their very first article that they tried to publish out of their data that they had collected at 23andMe, when they submitted it for publication, they couldn't get it published because they did not have any IRB approval for that work. And they didn't realize that they needed to do that to publish. They, as a non-signatory to the Common Rule, they didn't have to do that, but they did if they wanted to publish anything. Okay, so the Belmont Report, let's talk
You
about
want to say anything about Tuskegee for people who are not familiar?
I will just talk about that in a little bit.
Great.
As an example. So the Belmont Report, the ethical framework in the Belmont Report really corresponds, not coincidentally, to the principles that we talked about 2 videos ago. And that's because those principles really arose out of the work of the development of the Belmont Report. Instead of 4 principles, there were 3 principles. Respect for persons.
So that's autonomy?
No, it's called respect for persons.
Not autonomy.
Yeah, respect for persons. And autonomy then becomes a part of that. So autonomy falls under that.
Okay.
And then beneficence and non-maleficence comes under that. And then
Together?
justice. Sorry?
Benefits and non-maleficence are combined.
Correct.
And then justice.
Right. And then, of course, they also say that you need to have independent oversight of human subjects research or research on human subjects. And as a result of that requirement, in the US, institutional review boards, IRBs, were created. And in the rest of the world, Helsinki had the same requirement, but in the rest of the world, they call them research ethics committees. So research ethics committees in the rest of the world, institutional review boards in the US.
Research ethics committees. Are they shortened RECs?
Yes.
Because we say IRB all the time in this class. So that's
we'll say IRB, and we probably won't say REC.
Right.
So for Europeans in the class, IRB means REC. Okay, respect for persons which is the right of individuals to provide voluntary informed consent. So this is a bit of an oversimplification, but probably the most important way in which the respect for persons is cashed out is the requirement that if you're going to do research on human subjects in general, there are some exceptions, but in general, you have to get the voluntary informed consent from the person. Now, what does it take to have voluntary informed consent? that people have to have the capacity to make the decision. You have to adequately disclose enough information for them to be able to make informed decisions. And the decision needs to be free from coercion. In terms of beneficence,
Does coercion have a C or an S?
C.
Yeah, that's what I thought. Thank you for your patience. Go ahead.
Beneficence really is the idea that any research on human subjects has to minimize harms as much as possible and maximize benefits. So you want to minimize harms, maximize benefits, and then above all, the risks to research participants have to be reasonable in relation to the anticipated benefits of the research. And that includes both the benefits to the individual research participants, but also the benefits of the generalizable knowledge to be produced. Another way of thinking about this is just saying, look, we want to reduce the risks as much as we can, benefit as much as we can, but a lot of emphasis on that, reducing risk as much as possible. But it also has to be that the juice is worth the squeeze. If you're going to expose people to risk in a clinical trial, it's got to pay off and be worth it to expose them to the risks. Whether that's benefit to them or benefit to society, the juice has got to be worth the squeeze.
But it's important to stress that it includes the benefits to society.
Correct.
Which could change the calculation compared to a pure analysis based only on the benefit to the study subject, which may be minimal or even negative.
Right, which is really more like what we would do in clinical care. In clinical care, you'd be more focused on that ratio just for the individual. And then for justice, the big payoff there is that there needs to be an equitable selection of research subjects. So you want to make sure that your research subject selections are equitable, that risks and benefits of the research are equitably distributed.
Would that include things like the breakdown of sex and age distribution?
Correct. And you want to especially worry about what exploitation. You wouldn't want to have one group of people exposed to risks for something that's primarily going to benefit a different group of people, for example.
Right.
And one thing the Belmont Report did very presciently note, fair procedures, so even if you do things in a fair way, in a non-discriminatory way, could still produce unfair distributive outcomes as a result of, quote, social, racial, sexual, and cultural biases in society. And I thought that was very prescient that they were able to say to make that claim in the late 1970s, because that's become a big issue recently, especially in AI research, which we'll be talking about in a couple weeks. Okay, so let's talk about Tuskegee in more detail as an example. Why was Tuskegee wrong? People have probably heard about it, but what was unethical about Tuskegee? So in the Tuskegee syphilis study, this was an observational trial in which men were recruited from Tuskegee, Alabama, where they had very high rates of syphilis in a community of virtually entirely African-American men. And it was an observational study, not a clinical trial, in which they just wanted to understand and observe the natural course of syphilis in this population. They wanted to continue to study this population, and there are several things that they did that we could see that were problematic. From the point of view of respect for persons and the need to obtain informed consent, they actually lied to these patients about what they were doing. So in order to be able to get lumbar punctures, they told the participants that they had bad blood and that the lumbar punctures were treatments for their bad blood. So that's just one of many examples of ways in which they were misled and lied to and weren't told of all the risks and benefits and were misled, so that they failed to respect them as people and violated that principle. Second thing that was really important is they did not, because they wanted to understand the course of the disease, when antibiotics became available, penicillin became available later into the course of the study, they did not make that available to anybody who was in the study. They were all their physicians and everybody was told, don't let them have these things. And in fact, even if they developed unrelated infections, community physicians were told not to prescribe antibiotics or penicillin for anybody who was in the study. At that point, the risks of being in the study were pretty great, and given that this was not exactly the most well-designed study, it was just an observational study with very limited control. The juice was definitely not worth the squeeze. And so,
I should say, if I can, that syphilis is a sexually transmitted disease. I think most of you know this. Sexually transmitted disease, which when left untreated, leads to a huge range of damage to the patient in most of their organs, including their brain, and all of it is pretty much irreversible. So it is like a terrible disease to leave untreated. It was terrible to have before antibiotics, and then antibiotics were a miracle because I have never seen a case of active syphilis in my career as a doctor.
And so terrible burden benefit ratio. So they failed to meet the requirements of beneficence. And then third, it was an unjust distribution because all of the risks in this trial were being put onto relatively poor, uneducated African-American males to produce something that was a benefit to a broader swath of society, including more affluent and educated white populations. And so it was an unequitable distribution of people. So that's one of the reasons why it's sort of a classic case of an unethical research trial for all of those different reasons. Should we stop there?
That's pretty good. I leave it to you.
Yeah, I've got other examples, including more controversial ones, but maybe we should just stop there.
Let's just write what they were in case people want to read more.
Okay, placebo-controlled trials that have taken place for antidepression placebo-controlled trials when they were being well controlled on existing medications. And so there was some patients who committed suicide when they were off of their medications. So that was very controversial about whether the burden-benefit ratio was appropriate. And then even more controversially, because there were a lot of arguments on both sides. The editor-in-chief at the time of New England Journal said this was the new Tuskegee. At the same time, ethics leaders at NIH disagreed and said there was nothing ethically wrong in this. The HIV maternal fetal transmission trials. What was tricky there was they knew that AZT worked to prevent maternal fetal transmission, but it's a very expensive treatment that really was not an option in places like Africa and other different African countries, and in other parts of the world in less developed countries. And so they wanted to see whether or not a short course of AZT, which would be cheaper, would work. And so they did placebo-controlled trials in those countries. You could not do a placebo-controlled trial in the US because since long course AZT is available to everybody in the US, it would absolutely not be a good benefit burden ratio, and the risk would not be reasonable in relation to anticipated benefits. And more importantly, you would fail to minimize risks. Because you have to think about, when you're thinking about minimizing risks, you have to think about, are there alternatives? And since there's an alternative that works in the US, it would not be allowed. But in a country where the people don't have that as an option because the country doesn't have the resources to provide this, then in those countries, that's not available, so there is no alternative, and so then you potentially could get a positive risk-benefit ratio and claim that you're minimizing risks. Other people say you have failed to minimize risks, and the correct standard should be the best available anywhere, not just the available in those countries. And so people have been fighting about that case ever since.
Very good.
Okay.
This ends the module, and we'll see you at the next one.